Chris, thank you so much for your time today. How do you
Pleasure.
your surname, Gillespie?
Yes. Yeah,
Why?
that's me.
I don't know why I struggle with that, but Chris Gillespie is a colorectal surgeon and accredited for general and colorectal surgery, colonoscopy, and gastronoscopy, and is a clinical lead for the colorectal pelvic floor clinic at Queen Elizabeth II Hospital with skills in anal rectal physiology, assessment for functional colorectal disorders. Chris conducts private practice at Mater Private Hospital in Brisbane as well. Have I missed anything, Chris? Sorry about all those mispronunciations. Still easy.
No, I mean the only other thing I guess to mention is we have set up a similar clinic to what we have at QE2 in public and private, and that's called the Queensland Pelvic Floor Centre, which
Okay.
in fact I should mention, you may not be aware, we also have a branch which just opened in the Sunshine Coast in
Well, that
Nambour.
is amazing. So that's we're jumping straight to diagnosis and assessment, but
Yeah.
so you say it's public and private. Does that mean women can self-refer? How can
Yeah.
women get into this clinic?
Yeah, very easily. So
Yeah.
what we found was that patients were getting a bit lost
Yes.
between you because the care is really fragmented. So
Mhm.
good care for people who have some kind of pelvic floor problem, be it these patients will all have some form of issue with their bladder, perhaps an issue with prolapse, and perhaps an issue with their bowel, and or have all three of these problems at once, perhaps more of one and a bit less of another. And
Mm.
what we found is that people just got lost
Yeah.
but,
Yeah.
between seeing specialists, doctors, seeing physiotherapists, seeing dietitians, seeing other allied health specialists, and really when you bring all those people who treat pelvic floor problems together under one roof, you provide a much better service, and a much more holistic service. Um,
Mm.
most patients don't need surgery for
Mm.
these problems, and in fact, the goal is to try to, if you can get away with getting someone better without them needing to undergo surgery, that's a great outcome for them. So we
I
set
think it's
up,
really important to acknowledge because lots of women we support would want that they're thinking surgery
yeah.
because, I think that feels like, okay, that's a final and that's probably the solution because I just want to fix it and forget about it.
Mm.
But I think the reality is it's that holistic approach
Mm.
and conservative management, right?
Conservative management is
Yeah.
really important. And even if you do surgery, the outcome of surgery and the longevity of that benefit is improved if you
Mm,
treat all the other aspects of the dysfunction as well. So we set up this clinic in public in QE2 hospital, and
brilliant.
that's been successful, although it does, have the limits of working within the public system in Queensland Health. And then we
Yeah.
thought that we should do this in private. So in answer to your question, people can self-refer to the Queensland Pelvic Floor Centre, qldpfc.com.au.
Mm.
It is, you can just fill out an online form and you can meet a nurse practitioner and you can actually have anal rectal physiology studies done, including endoanal ultrasound, for free.
I was about to ask
That's
that. So
available to anyone. Mm.
yeah, okay. Because I remember actually, because I've seen you, I went to my GP to get a referral.
Mm.
But it's amazing that's, the cost, and especially in the climate that we're living in, is a huge barrier
Mm.
to care. So the fact that people can see you for free, obviously, I imagine there are wait lists
They
as well.
can see the nurse practitioner for free
Yeah, okay.
in the
Gotcha.
private clinic and have the test done.
Yeah,
But there is a cost with pelvic floor physiotherapy, and we have
okay.
really excellent experienced physiotherapists who are really central to the management of patients with these problems, and then obviously specialists myself, but also urogynecologist, gastroenterologist as well. So
I'm shocked that I haven't heard about this. We're going to have to talk a bit more about it offline because I feel
sure.
like you should know about this as a referral option. But let's just bring it back a little bit
Yeah.
because see, this is a Q&A for the ABTA community, but we will be putting it on our YouTube. So there potentially are women and parents listening to this that may not even know what we're discussing today when we're specifically talking about about OASI, which is a obstetric anal sphincter injury.
Yes.
Can you just summarize what an OASI is and perhaps how it's classified? Is
Yeah.
that terminology used in Australia, or is it more we refer to third and fourth degree tears?
Yeah, sure. So OASI refers to a vaginal delivery where the woman has sustained a tear to the perineum, and a grade 1 tear is a simple skin tear to the perineum. A grade 2 tear is where the tear extends into the soft tissue around the perineum and vagina.
Mm,
A grade 3 tear is where the tear extends even further and extends into the anal sphincter muscle.
mm,
The anal sphincter muscle is nearby, obviously, and the anal sphincter consists of an external sphincter and an internal sphincter. So a third degree tear is where the tear extends into the sphincter itself, and that signifies a more significant injury to the woman, and a higher risk of potential problems in the future, including in particular in my field, problems related to bowel function. A fourth degree tear is where the tear extends right through into the actual anal canal or rectum itself. These are obviously more obvious, and usually that's the one time where someone like myself as a colorectal surgeon may actually be asked to attend a delivery at the time to assist with a repair, because obviously the repair is quite complex.
mm.
Fortunately, fourth degree tears are relatively uncommon, but
Okay.
some type of third degree or fourth degree tear can occur in up to about 3% of deliveries in Australia.
So
Uh,
3%, what is that in 100? Is that about three, four people in 100 will have that
Yes,
kind
so
of
yeah,
test? Yeah.
up to about, yeah, say about that, three and a
Yeah.
hundred.
Yeah.
And of course, most of the time, hopefully that is recognized. And if it is recognized, then it can be repaired, and that repair is best done in the operating theatre.
At the time of
And
birth, is that
at
right?
the
Or
time of birth, yeah.
okay.
And obstetricians would do 99% of those, and they're very well trained at doing
Mm.
these repairs, and is important. And a patient is more likely to get a better outcome if the repair is obviously first of all identified and then repaired
Mm.
at the time,
Yeah.
as best as they can. Obviously, it's not as good as if it hadn't happened in the first place.
Mm.
But if it does happen, if you're unfortunate enough to have that injury, it's best that it's identified and repaired at the time. Yeah.
Okay. I think that's really important, that discussion around being identified at the time, because we have seen quite often in our support group, where we've got about 4,500 women in that group, and I do see a lot. And we actually, when we asked our community for questions, women talking about initially being diagnosed, say, with a second degree tear, and then
Mm.
often years down the track, they're told that it was actually a third or fourth degree tear.
Yes.
I'm interested to know, like, how common is this perhaps for you in your practice?
Yeah, no, look, I absolutely do see that.
Mm,
It does occur. The we do an endoanal ultrasound, so we pass a very small probe inside the anal canal. It's a little bit uncomfortable, not too bad, and it gives us actually pretty good pictures of the anal sphincter, and we're able to fairly well tell if there has been a significant injury in the past, a grade 3 injury. And we may even be able to tell if it just affected the external sphincter or if it also affected the internal sphincter.
mm,
And certainly a number of times, in fact, also the other way around. So sometimes I might say to someone who thought they had a first degree or a second degree tear, look, I'm sorry, but actually you had a third degree tear. But
yeah.
also, equally, to be fair, I have had people who've been told they had a third degree tear, and there doesn't seem to be any evidence of that when I do the ultrasound. So I think, I think obstetricians, to be honest, do a pretty amazing job, and I think it's actually really difficult at the time of delivery, where there's blood and recent delivery, and it may be difficult to determine exactly what's what. It's not quite as easy as it is in the pictures. And
Mm,
I think it is understandable that there may be some slight upgrading or downgrading or slight inaccuracy around it. What's important, I guess, is that if there is an injury that's significant, that it is identified at the time and an appropriate repair is done as best
mm.
as possible. But no, it absolutely does happen.
Yeah, I
Mm.
guess so. Then it would probably be good for the community to kind of know what are the symptoms that imply perhaps the severity of the injury. Like if we suspect that things are not right, is there
Mm.
a way, and like how do we sort of assess if we've got damage? Like with the first port of call, I mean, if it's in the early postpartum period, I presume you would go back to your care provider, be it your midwife
Yes,
or doctor. But
yes,
like over 6 weeks down the track, how can, would you recommend trying to get access to a physio, a pelvic health
yes,
physio, going to see your GP? I mean, this is, I think it's amazing that people can call on you at the time of delivery. You're based in Brisbane. But then I just think of all the women in those regional and rural areas that may be struggling with
yes,
symptoms. What would they do? Firstly, sort of what would those symptoms may be? And
yes.
if they suspect that they have a more serious injury, where do they go for help?
Yeah, I mean, what to me, there's a number of symptoms which are highly suggestive of a significant injury. One of the big things is significant pain. I guess when you have a baby, the problem is you have nothing to compare it to.
Mm,
If it's your first baby, you haven't had a baby before.
yeah.
So is this normal or is this not? But excessive pain, difficulty sitting down is a story
Mm,
you hear a lot that
mm,
lasts for weeks after delivery.
mm,
That's quite suggestive that delivery was particularly traumatic.
mm,
Patients may, I mean, fecal incontinence, so leakage of stool, difficulty holding on to gas, difficulty deferring going to the toilet, so being able to hold on and wait to find a toilet. Those are more obvious symptoms. Usually,
mm,
someone with those symptoms will sort of say, "Hey, something's wrong here." But some other people may find it actually difficult to go to the toilet. It might be painful to go to the toilet. They may have developed significant hemorrhoids. They may actually just have developed difficulty in actually adequately emptying their bowels, which is a surprisingly common and actually quite disturbing symptom to have. And any number of these symptoms can be suggestive of a traumatic delivery and a need for assessment.
mm,
Patients may have a slight dragging sensation in the vagina as well,
mm,
or some bladder symptoms. And so any of these things, I think that there's a tendency to normalize these symptoms and accept
mm,
them as normal. And it's really important to realize that there are things that can be done. It may be that you do have a significant injury, and you're likely to benefit by seeing someone who specializes in this area. And I think starting off with the two people that I think are most important to start with would be a specialist pelvic floor physiotherapist. So
mm,
someone, a physiotherapist who specializes in pelvic floor work,
mhm,
or your general practitioner,
mm,
and take a referral from there. Uh,
mm,
and just ask for some initial treatment. A lot of patients will get better with supportive care, seeing a physiotherapist, stool consistency adjustments, and time. And
yeah.
a young woman has an incredible ability to recover from even quite a traumatic injury. And symptoms that may be quite distressing early on, within a few weeks, can actually potentially even completely resolve.
Mm.
But then it's
That's
all
that
about
that is such a thing that we need to hear that they can resolve, right?
absolutely,
Yeah,
absolutely
yeah,
that they
yeah,
can. They
yeah.
don't always,
Hmm.
and even if that's the case, they can then quality of life can be optimized by seeing people who are able to optimize bowel function, optimize pelvic floor function, minimize pressures, and provide further counseling regarding management going forward.
Yeah,
Um,
I think it's that sort of um I always joke about this, but after experiencing a third degree tear myself, and then going to see a pelvic health physio, actually being taught how to go to the loo correctly,
yep.
it's just such a big thing. And then actually ensuring that we have the right type of stool or poo for those that aren't familiar with the terminology, but it's actually learning how to take care of yourself, like you say, in that holistic way as well, to prevent,
Yeah.
further issues as
And
well.
and not like we've discussed before, Amy, not everyone was normal before delivery as well. Remember
Yeah,
that
yeah.
problems with toileting, pelvic floor problems are actually very common, and not
Mm,
everyone coming into delivery was necessarily normal. And we know that if you come into pregnancy with some kind of problem with your pelvic floor, you're more likely to leave after delivery with some kind of pelvic floor problem which may have worsened. So So optimizing the way you're pooing, your lifestyle around toileting, even
Yeah.
your technique of toileting,
Yeah.
because after a traumatic delivery, your pelvic floor can respond in abnormal ways. It can try to compensate, and a physiotherapist who understands the complexity of how everything's connected in your body and the complexity of normal defecation can try and reinstitute a more normal defecatory technique, and that can lead to improvement in your symptoms as well.
Mm. I think, this is kind of, I would say when we're talking about birth injuries, it can be a bit of a taboo within a taboo because we are ultimately talking about the most private parts of our body.
Yes,
And do you think that that is a barrier to people seeking support? Like I'm going to make an assumption here, but would you say that a lot of the people that you're seeing are Anglo-Celtic? I mean, what are you seeing in terms of people from perhaps our multicultural community? Because my understanding is when we're looking at risks of these particular injuries, there's certain demographics that are at increased risk. Can you talk a little
there
bit
are.
about that?
Yeah, I mean, I look to be honest, by the time someone comes to see me, that they understand they're going to be talking about their bowels.
Yeah, yeah.
And in fact, I think often for them, facing the fact that their body has been changed by
Mm,
this delivery and
mm,
that potentially their body may not go back to how it was before delivery can be very hard to take,
absolutely.
very confronting, and can be in a very emotional journey. Because the reality is, some patients I see, many patients I see, we can't get them back to how they were before delivery, and it's about accepting what's happened.
Mm,
It's about moving forward and
mm,
saying, look, this is what's happened. We're going to work with you and we're
mm,
going to make your quality of life as best as we can. And we're going
mm.
to control your symptoms as best as we can. And we're going to keep that benefit and make you the best you that we can for the rest of your life moving forward.
Yeah.
And there's lots of ways that we can do that. And we can make people significantly better, but we can't always make people how they were before delivery. And part of it is, I guess, that grief process and accepting going through that. I see who I see, and you're right, the majority of people are Anglo-Celtic. But I see people who live in Brisbane and the people who are referred to me. But we do know that you're right. There are certain races that are more likely to develop an OASI, in particular, people of Asian descent. Uh,
Mm,
and surprisingly, a low BMI rather than
mm,
a high BMI
mm,
is a risk factor. So people who are underweight are more likely to develop an OAC. If
yeah.
someone in your family, so a family history of someone in your family, your sister, for example, has had a traumatic delivery, you are more likely to have one as well. And
Mm,
so there are not many ways that we can help someone who's not had a baby before predict if they're going to
okay.
get an oasis, but those are the risk factors that we are aware of. Along with that, there's also the length of the perineum, so the distance between the anus and the vagina
Hmm.
being a shorter distance, so less than
Mm.
2.5 centimeters is also a risk factor.
And so that could argue the case again, like as an organization, we really advocate for women to see a pelvic health physio prior to having a baby and then ideally afterwards. And these are
Yes,
conversations that I think pelvic physios are really well equipped to have about that sort of
absolutely.
functionality
Absolutely.
and those risk factors because this is the space in which they work.
It
Um,
is.
I think one of the biggest questions when we're talking about, okay, it's kind of tricky if they're a first-time parent, but what about pregnancy after a tear?
Hmm.
Since because this is probably the one of the biggest questions that we really see
Yes.
in this cohort is pregnancy and birth following a tear. So
Yes.
can symptoms get worse during the pregnancy, and what would management look like during pregnancy in that sort of ideal scenario if there wasn't cost as a barrier, for example?
Yeah, so I guess you've got a couple of things in that scenario. So you've got a young woman who's had a baby.
Hmm.
She's had a traumatic delivery. She's perhaps had some degree of loss of bowel control or some degree of abnormal bowel function or difficulties with her bowels after that first baby. Now, that may have resolved. So it may have been short-lived. It may have lasted 3 months, 6 months, 9 months, and now it's sort of better and she's okay. Or she might still be struggling with those symptoms even now. So there's two issues. There's how are you going to manage those symptoms during pregnancy, and then I guess there's questions about mode of delivery. So
Oh,
that's
that's a huge one. Yeah.
another, and these I do get these people referred to me for testing because this is one of the areas where we actually do have some evidence, so some
Okay.
actual scientific evidence, as we've talked about. There's unfortunately a lack of really good, rigorous longitudinal studies in the real effects of delivery going forward to quality of life and pelvic floor symptoms in the future. But this is one area where we do have some basis to make some recommendations on. And what we do know is that if you've had some degree of loss of control of your bowels or gas after delivery, then we can do an assessment and an examination and help to stratify the risk of a subsequent vaginal delivery in terms of that leading to further fecal incontinence. We know that about 9% of patients who have an OASIS can initially go on to who have a delivery without an OASIS can initially go on to have fecal incontinence, but that number actually goes up over time as well. So there are patients who may not have initially had fecal incontinence, but then go on to develop fecal incontinence later.
Mm.
What we know is that patients who have a persisting sphincter defect on ultrasound, so if we see that woman and we do an ultrasound and we find that there's a persisting sphincter defect of over 40 degrees,
Yeah.
or we find that when they squeeze their anus to hold on, they can't increment the pressure by more than 20 millimeters of mercury, then we know that they are much more likely to have fecal incontinence after a subsequent delivery. So if
Wow.
you see
Okay.
someone and they've
Yeah.
got, so for example, they've had a repair and it's
Yeah.
intact,
Yeah.
they don't have symptoms, and when they squeeze, they're able to increment a reasonable squeeze, then
Yeah.
the risk of them developing further fecal incontinence after a subsequent delivery, vaginal delivery, is actually relatively low. As
Okay.
opposed to if they did have one of those factors, then we know that it's relatively high. So we're able to, in this space, with these tests, actually provide some real data to women to help them to
Oh,
make that decision, which ultimately, as we've talked about,
yeah.
it's a personal decision.
Yeah.
But what we've talked about, it's important that it's an informed decision
Mm.
about
Mm.
what the real outcome of subsequent vaginal delivery versus, say, cesarean section would be.
I think that is incredible, firstly, to hear that. I guess my question to you is that sort of argues the case for women to come and see a colorectal surgeon to actually have this done. But
Yes.
if that is not a possibility due to financial or geographical barriers, is it a case of monitoring your symptoms but what you're saying is you might have no symptoms right now.
Yes.
Do you want to risk a percentage chance that you could end up fecally incontinent? Because that's what I've heard women be told, say, from their pelvic physio. So a lot of women that we support, again, fortunately, are able to access a pelvic physio, and a physio will say you might only have a 1 or 2% chance of being fecally incontinent. So it's kind of up to you and your risk appetite. I
Yep.
guess it's just that there's no kind of blank, it doesn't seem like there is any sort of clear guidance. Like I'm looking at something one of our community members said is there's limited data on the likelihood of a repeat third or fourth degree tear. I've been told 5 to 7% by an obstetrician, 20% by another. It's a huge difference. And this advice wasn't catered to my circumstances. They said these were they said these were the stats for anyone. So it's really difficult for people to make a decision. What
Yep.
yeah, what would you say about that?
So a couple of things.
Mm.
So what I've said to you is actually the RANZCOG, so that's the
Yeah.
Australia and New Zealand College of Obstetricians and Gynecologists recommendations. So
Yeah, okay.
they do actually recommend if you have some degree of fecal incontinence after delivery that you do have these tests that I've talked about.
Okay.
Now you're quite right that they're not available to everyone in Australia. There may be some people who are geographically isolated enough that they may not be able to access these tests.
Mm.
Like I said to you, that the service that we have in Brisbane and the Sunshine Coast is bulk billed, so there is actually no cost if you're able to get there, that is, of course.
Yeah, yeah.
If you're not able to access those services, I mean, I guess seeing a physiotherapist, if you have one around who's a specialist pelvic floor physiotherapist, is still going to be quite helpful.
Mm,
Aside from that, it's I guess that there is difficulty if you're significantly geographically isolated. I mean, if you're
mm,
able to travel for a
mm,
brief trip to have an assessment by one of these people that we've talked about,
mm.
then that does help. In terms of, I think it is a very individualized.
Absolutely.
What most women want is they want to know what's the risk for me, uh,
Mm,
and really, I think the best way to approach that is to sit down with a specialist physiotherapist or a specialist colorectal surgeon or obstetrician and talk about what symptoms or problems you may have had before pregnancy, what problems you've had since pregnancy, and then have a proper pelvic examination. So a
I love
pelvic
that. Yeah.
examination looking for particularly, is there any signs of mechanical dysfunction? For example, is the anal tone a little bit low? Is there a slight defect in the anal canal? Is there already some signs of slight loss of support? Is there a little bit of prolapse developing already?
Mm.
Is the perineum not quite as well supported as it should be? These
And it
things
can
will
be
give you a bit
shortened,
of a
right? If you've had a fourth degree tear,
your
would it?
perineum will be
Yeah.
shortened. I'm
Yeah.
talking as well just about when you strain to go to the toilet,
Okay.
does the perineum drop down a little bit further
Yeah.
than it should, i.e., is the entire pelvis less well supported than it should be? And
Yeah.
these things will be able to allow the specialist to individualize that advice to you specifically. I think your risk is a little bit higher than what the general numbers might say, or actually perhaps a little bit lower.
Mm.
And and counsel you accordingly. And
Okay.
ultimately, as we talked about it's about providing information because I think you've got to think about what the early problems that you encounter may be. Because
Yeah.
when you said before, 1 or 2%, I mean that's a very low rate. I mean, we know that the long-term reality of in terms of fecal incontinence after delivery is much higher.
Yeah.
But a
Yeah.
lot of fecal incontinence and a lot of prolapse problems occur years to decades after delivery. So,
Yeah.
so mothers might be looking at what they're facing in the first few months, but it's also important to talk about the rest of their life, the next few
Mm.
years, the next few decades,
Mm.
and how delivery may potentially impact symptoms that may occur a long time in the future. Pelvic organ prolapse peaks about 20 years after delivery. And
Okay.
so there is long-term
Yeah.
things to think about too.
And that is such an important statement because I think often when we're looking at birth, there's just this fixation on that birth being that the pivotal moment, that birth, and perhaps that we now really only look at the 6 weeks postpartum, which is
Mm.
completely inadequate.
Yep.
That is one season in the entire trajectory of a woman's life,
Yep.
and what happens at that delivery and immediately after will completely impact that long-term prognosis and those
Yes.
health implications. And I just don't think that that is addressed well enough. And that's why we're always talking about this. But I guess, in the interest of time, because I know you're busy and you're in your scrubs ready to go, I just want to ask, when someone has experienced an OAC or third or fourth degree tear, is there you often see a prolapse as well? And do the two kind of go hand in hand or?
Yeah, great question. So
Yeah.
yeah, what I would say is that the sphincter is something that we can easily measure.
Yeah.
We can put an ultrasound in, and the muscle's either together or it's not. So it's something that's easily measured. But really, to me, an OASI is just a marker of a particularly traumatic delivery.
Okay.
You can have a quite traumatic delivery without having an OASI. You
Yeah.
can develop fecal incontinence or bowel problems after delivery without having an OASI alone
Mm,
because there are other more difficult to measure injuries that occur higher up in the pelvis. And these are a bit harder to measure
mm,
and may many years later after pressure that occurs in the pelvis due to daily activities may manifest as prolapse or may manifest as problems emptying your bowel or fecal incontinence years after delivery. So really, an OASI to me is just simply a marker of a particularly traumatic delivery.
Okay.
So I think it's important to realize that that obstetric trauma is a more complex beast than I think. I think we oversimplify it by talking about just the anal sphincter itself. Yeah.
Yeah, I agree. And then I guess so. You did touch upon it before, but um, if there is a tear identified and you are kind of able to manage it, how often do you think people should be seeking to get it reviewed? Like in an ideal scenario, we would have a pelvic physio, but can our GP keep track of it? Like if we want to make sure that we're doing the right thing, how is the best way to do that? Because one of we got a lot of questions about sort of the symptoms and quality of life, in terms of, ongoing sensitivity,
Yeah.
painful intercourse.
Yep.
I think, lots of women struggle with being able to hold wind. And I think that that's a really difficult one. And again, like so much shame attached, that taboo
Yes.
within a taboo.
Yes.
Um, have you got sort of, I'm asking multiple questions at once, but I guess who do we go for review to make sure that we can keep on top of this? But I guess it's really important to put a disclaimer here. It needs to be affordable as well and accessible.
Yeah, this is a quality of life problem, and
Yeah,
most women will have more than one problem. As you've
yeah,
said, they might have a bit of pain that's persisting, trouble holding on to wind. They might have some stress urinary leakage. So when they jump on the trampoline, they lose a bit of urine. They may be getting up at night a few times to empty their bladder, for example.
mm,
So they may have all of these things at once. And what I guess our aim should be is to really just minimize those symptoms, maximize quality of life, maximize the impact that those symptoms have on that woman, and give that woman a chance to live the best life, I guess, that she can going forward. And the frequency of reviews really depends on, I guess, how we're doing with that. And
yeah,
so, if someone's continuing to suffer and they feel that this is a problem for them and it's really holding them back, then I'm going to be seeing those people a bit more frequently.
yeah,
We do continue to see people for years because we
yeah,
understand that this is a quality of life problem going forward. So some people may eventually say, "Look, I'm pretty happy with how things are. This doesn't hold me back at all. I can live a full life, and I may not need to see that person at all again." I think the most important person to see, however, is a pelvic floor physiotherapist, because what
mhm,
they will do is really, once you've got some degree of control, it's about prevention. It's all about prevention, and to prevent problems going forward, I think it's all about reduction in pressure.
mm,
So what we're aiming to do is we're aiming to not strain excessively when we're on the toilet. So we want to have good management of stool consistency. We want our bowels to be able to be evacuated without having to push and strain too much. And we need to know how to actually go about going to the toilet properly. We need to respond to the call to stool, and we
mm,
need to actually do the right thing when we're going to the toilet, because some people, they may say they're okay, but what they're actually doing to themselves every time they go to the toilet is just really pushing hard, and they're actually more likely to be back with a problem in the future. So seeing a physiotherapist, they're more able to ensure that what you're doing is the most physiologically or body friendly toileting technique, and
mm.
therefore you're more likely to be good for much longer, or hopefully forever.
Yeah. Before we actually hit record, we were talking about some of the women that you see in your practice, and obviously the women that we support, which is also, in that initial postpartum period, the trouble holding in a poo and actually not being able to leave the house until they know that they've
Yeah.
had a bowel motion, or women that aren't able to return to work. I think there's a sort of a sense that, will this ever get better? Can we do something? It's like fixing escaped wind, for example. That seems to be a huge question as well. Like, is it possible even with a severe tear, or do we just have to put up with it? Is this our new normal?
Well, yeah, I mean, look, the as I said before, we
Yeah,
can't change what's happened, and
yeah,
we can't get a time machine and go back and change the way the delivery happened.
yeah,
So yes, the reality is that we're left with with symptoms, maybe a changed body, and
Mm,
we have to manage that as best as we can going
mm,
forward. The
mm,
majority of people, we can get a lot better, and
mm.
we can get certainly quite a number of people to the point that this doesn't bother them at all.
Yeah,
The sad reality, and you and I both know it, is that some people, it becomes a management problem going forward, and it's
yeah,
about managing those symptoms, accepting them, and
yeah,
making the quality of life as good as we can. So often that may involve fiber supplementation. It may involve potentially some medication to help the anal sphincter squeeze better, and
hmm,
to perhaps even slightly constipate someone, and that may help with escape of wind. It may help with leakage, for example. It
yeah,
may be that we need to help better empty the rectum, and that may be by simply using a suppository in the morning or an enema in the morning,
yeah,
or perhaps in combination with a fiber supplement or laxatives, along with pelvic floor physiotherapy. And as a surgeon, I'm also looking for how good can I make this woman, and how happy or unhappy is she with that, and is there any other measures that I can do potentially, as a surgeon, that may enhance quality of life even more.
yeah,
And this is only a small percentage of people, but sometimes you might find someone who unfortunately has a persisting defect in their sphincter. Perhaps it wasn't recognized that they had such a bad injury at the time, or perhaps there was some kind of repair that was done, but unfortunately that has come apart. And despite all of your best efforts, she's still struggling with symptoms. The sphincter's still apart. Perhaps this woman may do well with a formal elective sphincter repair,
hmm,
which we do occasionally do.
yeah, yeah. You
It's
said
some,
it's not common though in your practice, so
it's not it's surprisingly not common, probably because most injuries are identified at the time and repaired at the time.
that was the
It,
case.
it,
I'm not sure about that.
it may be that
Yeah,
that there's actually a degree of prolapse
yeah,
that's occurred,
yeah,
and that there may be some surgery that may help with that. But
yeah.
really, surgery is best done when you've maximized all
All
other
of the others, yeah.
non-operative therapies, and you've got someone who's still struggling, who you really feel has a good chance of improving with a certain operation.
Yeah, I mean, I thank you so much for all of this. I think I hear this and I think of, I'm looking at all the questions. I've done my best to cover as many questions as we got. We did get a lot. But I think for any women listening to this, it's just so important to know that you're not alone and that there is help available. And even when you feel like you're the only one, I guarantee you there's someone else going through it and you don't need to suffer in silence. And that's why I'm so grateful for our community because we are able to connect women with other women that understand because it is so incredibly isolating. And
Well, I'm grateful for your community too, to be
yeah,
honest, because I actually
yeah,
refer these people to ABTA,
yeah, thank you.
and I say, look,
Yeah,
you're not alone. I
yeah,
understand this is really difficult and a really hard time, but the organization that you've set up is really powerful, more powerful than you
yeah.
think,
Yeah,
and
and I think it's also that gap that we're seeing now with this survey that we've recently done that our amazing community took part in, but that impact of actually either parenting or returning to the workforce and recognizing actually we shouldn't feel shame for what's happened to us and we need to find the power. And it is really, I can say it as a privileged Anglo-Celtic woman. I'm an open book and I'm quite happy to talk about my anal sphincter and my pelvic floor muscle and my broken vagina and have these conversations with a man that's actually seen my anus. And, like I laugh about these things. But I think in talking about this stuff, even if it is just with one person, it reduces that sense of shame and that sense of isolation. And people might find that they connect with somebody else that's also going through it. So
no, that they love
yeah,
here. I just
yeah,
start talking about,
yeah,
I see other young women with these symptoms, and
yeah,
start to, telling various stories, and
mm,
immediately people are just happy to hear that they're not the only one, because
mm,
it's a common feeling, and
yeah,
and yeah, it's a dark space that people can get into, and
mm,
and obviously, as we talked about before, you've got postpartum depression going on, you've got PTSD going on. It's a difficult space that you can enter, and it is important to know that yeah, you're not alone, and there are people out there who can help you
Mm,
and work with you.
yeah.
Sure, we may not be able to undo what's
Yeah.
happened. And
Yeah.
that's the hard thing, I think. And
Mm,
I find that hard as well to talk to people about, because it's just the reality.
mm,
But we're gonna get you as good as we can get you, and it's
mm.
probably going to be a lot better than where you are now.
Yeah.
And
Yeah.
work with you and make you the best you that we can going forward.
Love that. I really love that. Thank you so much for your time, Chris. Really appreciate it. It's good to see you. It's been a while.
It has
And
been all good.
yeah, I'm sure this won't be the last conversation because I could talk to you at length.
That's right, as we have been. Thanks.
Yeah. Yeah. Have a good afternoon. Thanks everybody for listening. And you can find Chris. I'll put his details in the YouTube link. And yeah, shout out. And of course, you can always get support from birthtrauma.org.au.